Okay, let's talk about respiratory failure and support. Learning objectives. Differentiate between hypoxemic, hypercarbic, and mixed respiratory failure. Describe a stepwise approach to oxygen therapy. List the indications for mechanical ventilation. And differentiate between non-invasive and invasive ventilation. And then at the end, we'll talk a little bit about upper airway obstruction just for fun. This is not a lecture on how to manipulate a ventilator. We will cover some basic concepts, but really this is a foundational lecture just on respiratory failure and some core concepts. So what is respiratory failure? Well, respiratory failure is something that you know it when you see it, and it takes time to figure it out. It is not completely cut and dry. It's not a single number. It's not a single anything. You know it when you see it. That said, there are a few things to consider. I would say it is the body's inability to maintain a normal oxygen and CO2 level without significant support. But what does significant support mean? Well, in my world, I know it when I see it, but significant support to me would mean something more than a nasal cannula or a face mask. It would be BIPAP, CPAP, or invasive ventilation. There are definitions out there for studies and for practical purposes, but again, it's not that cut and dry. That said, hypercarbic respiratory failure, you could say, is a P(a)CO2 of greater than 50 millimeters of mercury. What about hypoxemic respiratory failure? Oh, before I do that, you can have acute hypercarbic respiratory failure, you can have chronic hypercarbic respiratory failure, and you can have acute on chronic hypercarbic respiratory failure. Acute respiratory failure. Patient comes in with a horrible pneumonia. They have acute hypercarbic respiratory failure. Chronic hypercarbic respiratory failure. Patient has horrible COPD, and no matter what, his PCO2s are crazy high. Acute on chronic hypercarbic respiratory failure. That is a classic example of someone who has chronic respiratory failure and then gets sick with something else. So you could imagine a patient with spinal muscular atrophy. They are weak at baseline, and because of that, they have hypercarbic respiratory failure. That's chronic. But then all of a sudden, they get a pneumonia or they get a virus, and they get worse. That's acute on chronic hypercarbic respiratory failure. Now for the hypoxemic respiratory failure. Hypoxemic respiratory failure, if you want a number, is a P(a)O2 of less than 60 millimeters of mercury. Again, it is not completely black and white, but that's a nice number to think about. And this is all without significant support. So if you are on a little nasal cannula and it takes your P(a)O2 from 55 to 90 with a little bit of nasal cannula, that's not hypoxemic respiratory failure. But if you start with a little PaO2 of 45 and you have to be on a ventilator to get it up, well, that is respiratory failure. And then you can have mixed respiratory failure, which is a combination of both hypercarbic and hypoxemic. So let's drill down on hypercarbic respiratory failure. We'll also cover this when we talk about hypo and hypercapnia next week. So hypercarbic respiratory failure can be from a decreased minute ventilation. You can't breathe or you won't breathe. What do I mean by that? You can't breathe. You were paralyzed by botulism. You can't breathe. You won't breathe. Well, you won't breathe because maybe you have taken a narcotic and your respiratory control centers are diminished. Increased dead space relative to minute ventilation. Remember, minute ventilation is both a combination of alveolar ventilation and dead space ventilation. And if your dead space ventilation goes up, then your alveolar and your minute ventilation stays the same or doesn't go up enough. Your alveolar ventilation will go down because the ratio will get smaller. And this can lead to hypercarbic respiratory failure. This happens in illness all the time. Someone gets a horrible pneumonia, they have increased dead space ventilation. Their minute ventilation increases a little bit, but not enough to compensate for that increased dead space ventilation, and they develop hypercarbic respiratory failure. Finally, let's talk about increased production. What do I mean by increased production? Well, there are times in your life when you produce more carbon dioxide. When you exercise, you produce more carbon dioxide. When you're sick and have a fever, you produce more carbon dioxide. And all of us will breathe faster. We'll have a little increased minute ventilation. Not only faster, but probably deeper. But let's say that you have increased production and either you have something wrong with your lungs or something wrong with your respiratory control centers and you can't increase your minute ventilation. Well, simply having increased production and not being able to compensate for that by increasing your minute ventilation could also lead to hypercarbic respiratory failure. What about hypoxemic respiratory failure? Well, you can have decreased inspired pressure of oxygen. You can have hypoventilation. You can have low VQ mismatch. You can have shunt. And you can have diffusion abnormality. Wait, we've seen those all before. Those are the 5 causes of hypoxemia. And if they get bad enough and they can't be improved with a simple nasal cannula or simple treatment, you develop hypoxemic respiratory failure. Let's do a case. A 9-year-old girl presents with a 5-day history of fever and cough. Here are her vital signs. She's febrile. She's got a normal blood pressure for a 9-year-old. Her pulse is 110, a little bit fast, but not horrible. Her respiratory rate is 22, maybe a little fast, but not horrible for a 9-year-old. And her oxygen saturations are 84%. Well, that's low. On her physical exam, she's got decreased breath sounds on the right axilla, but otherwise looks pretty normal. She's not working hard to breathe. She looks like she's breathing comfortably. This is her x-ray. Oh, that looks like a right middle lobe pneumonia, doesn't it? So what do you do next? Do you intubate her? Do you order a blood gas? Do you place her on a nasal cannula, a face mask, a non-rebreather, CPAP or BIPAP? I'll pause. You take a guess. What do you do next? You place the patient on a nasal cannula. How did I know that? Well, I look at her vital signs, and like I said before, they're not that bad. And I look at her work of breathing, and based on this clinical exam, she has no accessory muscle. She's breathing comfortably. So I think that I should try a nasal cannula. I should do the lightest touch first, and all of these other ones are a pretty big deal. Intubation, sticking a tube in someone's throat, that's a pretty big deal. Blood gas, I don't know if you know this, but that hurts. So you shouldn't do that unless you really have to. A face mask is more oxygen than a nasal cannula, a non-rebreather even more, and then CPAP and BIPAP are mechanical ventilation. So what type of respiratory failure does this patient have? This patient does not have respiratory failure. How do I know? Because she doesn't look like she has respiratory failure, and you know it when you see it. I don't need a blood gas to tell me whether she has or does not have respiratory failure. She's got pneumonia with a little hypoxemia, and I can get her better with a nasal cannula. So let's talk about nasal cannulas, and this is the stepwise approach to oxygen delivery. Nasal cannula. You can usually do between about 0 and 4 liters per minute, and it just flows into the nasal cannula. You can usually achieve anywhere from about 0.25 to 0.4 fraction of inspired oxygen. Some people will refer to that as 25 to 40% fraction of inspired oxygen. It depends on both the patient's minute ventilation and also the flow rate of a nasal cannula. Remember, room air is 21%. And if it lasts long enough, or if you've ever had it before, you know this, it can dry and irritate your nares. What about a face mask? Well, there are lots of different types of face mask, but let's start with the simple face mask. The simple face mask, you can usually blow in between 6 and 10 liters per minute. It can achieve about 35 to 50% FiO2, or again, if you're using fraction, it's 0.35 to 0.5. And a non-rebreather is different than a face mask. Whereas in a face mask, and I'll use my cursor here, it has little holes in it. When you breathe out, you ventilate through these holes. And when you breathe in, some air goes through these holes in. So you cannot achieve a perfect amount of oxygen. Whereas a non-rebreather, here's a little bag that collects oxygen. It's an oxygen reservoir. When you breathe in, you've got these little one-way valves that stop air from coming in from the outside world, but when you breathe out, the air expires through these little valves. That's a non-rebreather. And you use between 10 and 15 liters of flow per minute. In fact, if you do less, you're suffocating the patient because they can't get any air anywhere else. And it achieves somewhere between 60 to 100% FiO2. In theory, a non-rebreather provides 100% FiO2. So we've talked about nasal cannula, we've talked about face masks, and now we've talked about a non-rebreather mask. The other masks here on this picture are less important for what we're talking about right now. And as I said earlier, a non-rebreather mask has a one-way valve to allow for release of CO2. Otherwise, you'd be in a world of hurt because you couldn't expire your CO2. So, when would you choose a face mask over a non-rebreather mask over a nasal cannula? Again, complex question based on clinical experience and what the patient looks like. If the patient doesn't look that sick and they're not that hypoxemic, meaning their saturations are in the mid to high 80s, try a nasal cannula. If they look really sick, you might want to try a non-rebreather or a face mask until you get ready for more invasive mechanical ventilation. So, I'm sorry, not invasive, but mechanical ventilation. Let's go back to this girl. Now, she comes in and she's got 5 days of fever and cough. Her temperature's the same, her blood pressure's the same, her heart rate's about the same, but her respiratory rate is 45 times per minute. That's crazy fast. That's twice normal. Her oxygen saturations are 87%. And when I look at her, she's listless, meaning she's not alert. She's just laying there. She's got subcostal and intercostal retractions. What do I mean by subcostal and intercostal retractions and listlessness? Like I said at the beginning, sometimes you just need to see it. And this is a picture of a patient of mine who has pneumonia, who comes in, who's listless, she's struggling to breathe, she's breathing fast, and she's got retractions all over. So that's what respiratory failure looks like. What do you do next? Well, in this case, I would intubate her. I think some people would say, well, maybe you should put her on a CPAP or BIPAP or something else. But I'm going to tell you why in just a minute, why I would intubate her and skip the non-invasive mechanical ventilation. Again, respiratory failures, you know it when you see it in most cases. And what type of respiratory failure does this patient have? I don't need a blood gas actually to tell me that she has mixed respiratory failure. And the reason why I say that is because she's hypoxemic. She's really struggling to, she's hypoxemic. Her saturations are 84%. She's breathing fast and shallow and hard, which means that she probably is not ventilating very well. And she's very listless, which tells me that her CO2s are elevated and she can't wake up. So, indications for mechanical ventilation. I put them in 3 buckets. Respiratory failure. And again, respiratory failure can be hypercarbic, hypoxemic, or mixed. That's the first indication. The second indication is inability to protect your airway for whatever reason, whether it's a procedure, whether it's surgery, whether someone jabbed you in the neck with a pen, whether you have anaphylaxis and your throat is swelling up. Inability to protect your airway. Or circulatory failure. What do I mean by circulatory failure? Sometimes shock is a reason for mechanical ventilation. Those are the 3 indications: respiratory failure, inability to protect your airway, and circulatory failure. So let's dig into mechanical ventilation a little bit. I grouped mechanical ventilation into 2 modes: non-invasive ventilation and invasive ventilation. And under non-invasive ventilation, I have continuous positive airway pressure, which people refer to as CPAP. You will see this with your uncles who have obstructive sleep apnea. Or bilevel positive airway pressure, which is BiPAP. And we'll talk about the difference in a second. For invasive here's a picture of your uncle on BiPAP at home over Thanksgiving. They come in a bunch of different ways to put the mask on your face, either a nasal mask or little nasal pillows or a full face mask. This is invasive ventilation. When you stick an endotracheal tube into the mouth, past the larynx into the trachea, and you deliver flow, pressure, and oxygen straight to the lungs. So mechanical ventilation means you're helping ventilate and oxygenate with a machine, but it can be non-invasive or invasive. So we listed the indications for mechanical ventilation initially. So what are the indications for non-invasive mechanical ventilation? They're the exact same except for one thing. Anyone who can't protect their airway should not be on non-invasive mechanical ventilation. And that's why I chose to intubate that girl initially instead of put her on BiPAP or CPAP, because I didn't think she could protect her airway. She was too listless. She was fatigued. She couldn't wake up. But otherwise, oftentimes, you can try non-invasive ventilation as a first step before going straight to invasive ventilation for patients in respiratory failure. And most of the time it works pretty well. Do we ever jump over the step between nasal cannula and then to face mask, then to non-rebreather mask, then to BiPAP, then to intubation? Do we ever go straight from I see this patient directly to intubation? We absolutely do. And again, it's just something that you get comfortable with and know that the initial steps aren't going to help and you need to go straight to controlling the airway. What about circulatory failure and mechanical ventilation? Why would mechanical ventilation help circulatory failure? It's a complex process, but I think it's pretty interesting. Mechanical ventilation can decrease oxygen demand by reducing the work of breathing. And remember, circulatory failure or shock is just a discrepancy between oxygen demand and oxygen delivery. And so if you can decrease the oxygen demand in whatever way you can, whether it's work of breathing or getting rid of the fever, you're going to help shock. There's one little nugget or caveat you need to know about mechanical ventilation and shock. It has to do with the physiology of positive pressure ventilation. Remember, mechanical ventilation is different than our normal natural ventilation. In mechanical ventilation, where you're pushing flow, we are pushing pressure into the lungs. And when we do that, we increase the intrathoracic pressure. And if you have increased intrathoracic pressure, you can decrease the preload of the left ventricle. Well, why is that? Well, preload is based on SVC and the IVC draining into the right atrium. And if you have increased intrathoracic pressure, that SVC and IVC have to work harder or drain kind of upstream to get back to the right atrium. And that can lead to decreased preload. And you can imagine if you have someone who's mechanically ventilated and in shock and you decrease their preload, if they have hypovolemic shock or distributive shock, you can make things worse. So just something to think about based on physiology. And as you get into your clinical environments, you'll learn more about it. So how does mechanical ventilation work? It is complex, and if you want to learn a ton about it, you have to end up being a critical care doctor. But there are a few foundational concepts that I think are really helpful. Before we do that, there's some terms I need to go through. Here we go. CPAP stands for constant positive airway pressure. BiPAP stands for bilevel positive airway pressure. PEEP stands for positive end expiratory pressure. PIP stands for peak inspiratory pressure. Rate equals the number of breaths per minute. And tidal volume is the size of each breath in milliliters. So we'll go through each of these in detail now. So, how does mechanical ventilation work? What is the PIP? What is the peak inspiratory pressure of this patient? Here we have, these are called flow diagrams. This is time, and on this axis, the y-axis, we have volume here, pressure here, flow here. So what is the PIP? What is the peak inspiratory pressure for this patient? The answer is 30. And how do I know that? Well, I can look at the pressure tracing of pressure versus time, and I can see that the peak pressure that this patient ever receives is about 30, where that red line is. There you go. And this patient is receiving with every breath a pressure of 30 centimeters of water. Every time the patient receives a breath from the machine, they're getting 30 centimeters of water of positive pressure. So that's what PIP is. What is PEEP? Remember, PEEP is the positive end expiratory pressure. It's the pressure that the patient never goes below in between breaths? The answer is 6. And how do I know that? Again, I look at the pressure tracing here, pressure versus time, and I look to see how low it goes. And it goes to about 6. Between every breath, the patient's pressure drops to 6 and never goes below that. What is the tidal volume of this patient? It's right here. And you can see that in this patient, the tidal volume is varying with each breath. But again, volume versus time, it's about 600 right here, maybe 450, and back to 600. So that's the tidal volume that the patient's receiving with each breath. So what determines the size of each breath for a patient on mechanical ventilation? It's the change between the PEEP and the PIP, and the dynamic lung compliance. So if PEEP and PIP stay the same, you can imagine the tidal volume will vary based on how compliant the lungs are. And for this smaller breath, for whatever reason, the patient had suddenly less compliant lungs. So mechanical ventilation's tidal volume is determined by the difference between the top pressure, the PIP, and the bottom pressure, the PEEP. And you can make the tidal volumes bigger or smaller by making the difference between the PIP and the PEEP larger. But really what controls the breath size is not only that difference in the PIP and the PEEP, but also the lung compliance. If you have a stiff lung, you're going to have smaller tidal volumes. If you have very floppy lungs, you'll have larger tidal volumes. Okay, a 4-year-old girl presents with 5 days, fever, and cough, and she's now intubated. This is her blood gas. 7.24 with a CO2 of 60. Her PaO2 is 95. Her bicarb is 24. And her oxygen saturations are 97%. What can I change on the ventilator to improve this blood gas? You'll recognize that this blood gas is a respiratory acidosis, and it's acute. So what can I change on the ventilator? Do I increase the FiO2? Do I adjust the PEEP? Do I increase the rate or increase the tidal volume? You can either increase the rate or increase the tidal volume. When you have an elevated CO2, you have less minute ventilation than you need. And there are only 2 things that control minute ventilation: rate and tidal volume. So let's go back to how mechanical ventilation works. In hypercarbic respiratory failure, when you have a CO2 that is elevated, you can also have hypoxemic respiratory failure where your O2 is too low. In hypercarbic respiratory failure, you always want to increase the minute ventilation to improve your CO2. And you can do that in one of 2 ways. You can increase the rate of the breaths that you deliver, or you can increase the tidal volume of the breaths that you deliver. So now I have a girl who has a pH of 7.38. Her CO2 is 42. Her PaO2 is 50. Her bicarb is 24. And her oxygen saturations on this blood gas are 81%. Does she have a respiratory or metabolic acidosis? She does not. So I go to the 5th step in interpreting a blood gas, and that is the PaO2. Is 50 normal? 50 is not normal, particularly when you have saturations of 81%. So how can I improve her oxygenation? What can I change on the ventilator to improve it? The same options: increase the FiO2, adjust the PEEP, increase the rate, increase the tidal volume. I've got 2 choices here. I can either increase the fraction of inspired oxygen or adjust the PEEP. In hypoxemic respiratory failure, when your problem is with oxygenation, you can increase the FiO2. Remember, room air is 21%, and I can increase the amount of inspired oxygen all the way to 100%. And that will help me oxygenate. The other thing I can do is I can adjust the PEEP, the positive end expiratory pressure. clinically, what most people understand is just by increasing the PEEP, by going up on the PEEP, going up in that pressure at the end of expiration, you will make oxygenation better. You likely have seen this graph before. It has ventilation or perfusion per unit lung volume on the y-axis. It has rib number on the x-axis from bottom to top. The lowest rib to the top of the rib. And then it's got all these lines. And then on this y-axis, it has the ventilation to perfusion ratio. I don't like this graph, but I'm going to walk through it one at a time. The first line shows perfusion, and it shows that as you go from the bottom of the lungs to the top of the lungs, flow gets less. The second line is ventilation. In addition, as you go from the bottom of the lungs to the top of the lungs, ventilation gets less as well, though not as steep. And then you put those two on each other, and you can calculate the ventilation to perfusion ratio. And remember, when you have a ton of ventilation and almost no blood flow, you have what we refer to as dead space. That's what happens in your trachea. You're ventilating all the time in your trachea, but since you don't have any blood flow, you have dead space. And when you have a low VQ mismatch, you have a ton of blood flow and not very much ventilation. And where we all have our best ventilation perfusion ratio is right here when we live at our optimal functional residual capacity. Our body naturally keeps our lungs aligned in a space that allows for optimal ventilation perfusion matching, which allows for optimal oxygenation and optimal ventilation. So what happens when you're sick? When you're sick, your functional residual capacity can get bigger. It can get overexpanded. This happens in obstructive lung disease. Patients with obstructive lung disease have huge amounts of lungs, and their functional residual capacity that they sit at naturally is bigger than it should be. This happens in COPD, it happens in asthma. When you get sick in other ways, you can get restrictive lung disease, and your functional residual capacity gets a little bit smaller because your lungs are smaller. This is also not good. Restrictive lung disease can happen in pneumonia, it can happen in ARDS, it can happen with scoliosis, it can happen with obesity. So how does positive pressure and increasing the PEEP help? How does it help oxygenation? Well, when you increase the PEEP, you expand the functional residual capacity back to an optimal point. By increasing the pressure in restrictive lung disease, you allow the lungs to expand back to a place where they have optimal ventilation and perfusion matching. What about obstructive lung disease? How does it work there if the lungs are already overexpanded? Well, the PEEP actually stents the lungs open and allows for more air to expire, and your functional residual capacity goes smaller, back to an optimal spot. So PEEP works to improve oxygenation by expanding or decreasing the lungs to optimal functional residual capacity. It optimizes flow, it optimizes ventilation, and it optimizes the ventilation perfusion matching. This is a core concept. Functional residual capacity is where we do our best. But when you get sick, your functional residual capacity can get too small in restrictive lung disease or get too big in obstructive lung disease. And then you have all sorts of problems. In mechanical ventilation, by blowing in pressure and keeping the lungs better expanded or less expanded, improves oxygenation. So, to summarize, when you have CO2 problems, you increase the minute ventilation by increasing respiratory rate or tidal volume. When you have oxygenation problems, you increase the FiO2 or increase the PEEP. Completely separate approaches to two separate problems. So, what about CPAP and BIPAP? Well, CPAP is really just PEEP when there's no PIP. It's a constant pressure all the time. So this patient is breathing like this. They're breathing, 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 but you can see that they never go below 5 because they have a CPAP of 5. They're living at their lungs being optimally expanded at an optimal functional residual capacity. And BiPAP is just PEEP and PIP together, but it's used in non-invasive ventilation. So you have a peak pressure and a lower pressure. The peak pressure expands the lungs, but the lower pressure never lets the lungs get below a certain functional residual capacity. Let's summarize it. In hypercarbic respiratory failure, again, you can increase the minute ventilation, you can increase the rate, or you can increase the tidal volume. And so for patients in hypercarbic respiratory failure, it makes sense that non-invasively that you would use BiPAP, that you would use something that will increase their tidal volumes, because you have both a lower pressure and a higher pressure. In hypoxemic respiratory failure, you can either increase the FiO2 or adjust the PEEP. And so it would make sense, since CPAP is kind of like PEEP, that for hypoxemic respiratory failure, you could use non-invasive ventilation of CPAP. This is very basic. There are definitely times when we mix and match and use some of both. But in general, you could think that if you have hypercarbic respiratory failure, you need to increase your tidal volume, and so that's what BiPAP does. And if you have hypoxemic respiratory failure, you need to increase, or you need to bring your functional residual capacity back to an optimal level, and you can use CPAP for that. Bonus time. A 9-month-old girl presents with a 1-day history of barking cough, worse at night. She's got temperatures of 38.6, a blood pressure of 74/44, her pulse is 160, her respiratory rate is 55, which is fast. She's breathing 94, she has 94% oxygen saturation. On her physical exam, she has these pertinent positives. She's listless again. She's not really waking up. She has subcostal and intercostal retractions. So in addition to breathing really fast, she's breathing really hard. And you hear this just walking in the door. That, my friends, is what inspiratory stridor sounds like. As she's breathing in, you hear that squeaking noise. So what do you do next? You've got A through H as options. You got a ton of options here. What do you do next? It's a lot of options to go through, so I'm going to wet my mouth. Oh, she's got this x-ray that your friend got. What do you think she has? She's got croup. This is the classic steeple sign, where it's very small right here, right below the larynx. So the treatment for croup is actually racemic epinephrine. Let's talk about why. So croup. It's classically caused by parainfluenza, but it can be caused by lots of other viruses. The problem is swelling right below the airway. Right below the glottis, the subglottic airway. You have the steeple sign on X-ray, and you hear inspiratory stridor. Now the physics group, one of my favorite. It's all about resistance. My friends, my friends, my friends. Remember turbulent and laminar flow from cardiac physiology? And how the radius is proportional to resistance. As the radius gets smaller, the resistance goes up. In laminar flow or steady flow, it goes up to the 4th power. In turbulent flow, it goes up a lot more. And remember that as resistance goes up, flow goes down based on Ohm's law. And so as the resistance goes up in these tiny little airways, patients don't get enough airflow. And the treatment is really just about increasing the radius and decreasing the resistance. And we do this in one of two ways. We give steroids, which decrease inflammation and over time improve things, and we give racemic epinephrine. Racemic epinephrine is just inhaled epinephrine, and they use the term racemic because it's both isomers. And it decreases the swelling therefore increasing the radius through its alpha-1 properties, which cause vasoconstriction. And since blood flow can't go as quickly to this area, swelling decreases. We do one other thing. We try to get rid of the turbulent flow, because remember, a stridor is turbulent flow. You can only hear turbulent flow, and we try to get it back to laminar flow. And we do this in one of two ways. We calm the patient, so decreasing the velocity and how much the patient is pulling will help us go back to laminar flow if you slow things down. And we give something called heliox, which is a combination of helium and oxygen. And heliox has less density than oxygen by itself. And based on this thing called Reynolds number, which we alluded to again in cardiovascular physiology, the less dense allows for more laminar flow. So that's croup. What about epiglottitis? Well, it's classically caused by Haemophilus influenza, but it can be caused by other bacteria as well. We still see epiglottitis almost never with Haemophilus influenza because of the vaccine, but we do see it with other types of bacteria. It's swelling of the epiglottis, which is the little floppy thing above the airway. And you see the steeple thumbprint sign. And you can have inspiratory stridor just like croup, but unlike croup, these patients look like they're going to die. They look tough. Okay, last question. This is going to help us review the concepts on mechanical ventilation. A 35-year-old male is intubated with pneumonia. Here's his blood gas. I think you've actually seen this before. He has a respiratory acidosis. He has hypercarbic respiratory failure. But his oxygenation looks like it's okay. So how do you improve the patient's blood gas? Do you increase his PEEP? That's the positive end expiratory pressure, the pressure that the lungs never go below. Do you increase the FiO2? Do you increase the PIP? That's the peak inspiratory pressure. Or do you decrease the PIP? You would increase his PIP because his problem is in minute ventilation. He has too high of a CO2, and therefore his minute ventilation is not enough. And why does increasing the PIP help with minute ventilation? So what determines the size of each breath? It's the change between the PEEP and the PIP. Here's the PEEP, and here's the PIP. And as you make that PIP higher, you can make this difference bigger and therefore increase the tidal volumes. And remember, the other thing that affects tidal volume size is lung compliance. And if his lungs are really stiff, you may need a ton of difference, what we refer to as delta P, change in pressure between the PEEP and the PIP. Okay, let's just go over the learning objectives one more time. Hang with me till the end. We differentiated between hypoxemic, hypercarbic, and mixed respiratory failure. And again, there are some numbers out there, but really you just know it when you see it. We talked about a stepwise approach to oxygen therapy. You start with nasal cannula, you go up to face mask, then you go to non-invasive mechanical ventilation, and finally you go to mechanical ventilation. We talked about the indications for mechanical ventilation: respiratory failure, circulatory failure, or can't control your airway. We differentiated between non-invasive and invasive. And with that, as always, I bid you adieu.